area, and what you do, you take the inferior frontal gyrus, you take the superior temporal gyrus, you go transcortical. And why you do that? This is natural cleft. God created this for us to reach these lesions. But we avoid dissection, right? And when you avoid dissection, you think you are minimizing the injury. Actually, you are maximizing the chance of injury. Okay, so don't do that, please. Like this. This is a tumor, GBM, and there's a surrounding T2 flare, T2 changes. So this is the high grade part. This is probably this tumor was actually molecular biology wise was probably developing from the low grade tumor and eventually turned to be a GBM. So why should I take these gyri, right? I don't need mapping. Yes, I need adjuncts, but I need my anatomy. Anatomy tells me do the correct craniotomy and pay attention to these veins. Okay, don't take these veins early. If you take them, opercular becomes congested, start oozing, and you start damaging the cortex. Okay, so then these arteries, insular MCA branches, they travel within the insular gyri. Okay, they are not engulfed, and they give these tiny feeders to the tumor. They used to be insular branches going to the insula. So you pay attention, you do your dissection, preserve the veins, preserve the arteries, take the feeders one by one, and so you don't need to do any transcortical approach. And all the veins are preserved. Okay, and you remove the tumor. You don't remove the normal brain. So these very important, and please pay attention to these veins early and try your best dissect the sulcus or fissures. And this patient survived more than 4 years, eventually had multiple recurrences, distant recurrences, and died at around 5 years. And this is another tumor. This is again insular GBM extending towards the anterior perforated substance. So that tells me I have to be very careful with lenticular striate arteries. That's lenticular striates are going right to the anterior perforated substance. So, and again, same thing. Pay attention to the veins. Be careful. Apply microsurgical techniques. Wide sylvian fissure opening. Mobilize the veins away from your field. Push them away. There are some variations. Don't give up. Only take very small veins if they are bridging. Okay, don't take the major veins. And if you skeletonize them, you can apply traction. And now lenticular striates. Again, tumors going to the arteries going to the tumors, I take one by one and make sure they are not long perforators. Okay, rarely these lenticular striate arteries can go. The insular arteries can go to the corona radiata. That's the around 5% chance. Then you can reach everywhere transsylvian lenticular striate arteries encased by the tumor. This is true encasement. So please don't do this dissection if you are inexperienced. Okay, you have to gain experience. You need to know how much you can pull, how close you can cut, and that comes with the dissections in the lab. You learn how to dissect the P arachnoid of the cadaver. Okay, and then you can do these things. See, I'm dissecting the lenticular striate artery. And but I know how much I can pull, and you can use low intensity ultrasonic aspirators on these arteries. Okay, so I'm dissecting because this is the only time this patient has. I do my best to do gross totalization. If I cannot, this patient has no chance to beat the odds because it's GBM. And this patient, like huge insular glioma. Yes, sometimes we encounter problems, right? This is again same style. I'm gonna fast forward this because again same thing. I open the fissure, spend time, preserve the arteries, veins, take the tumor. And when you are dealing with the insular gliomas, you are vascular neurosurgeon, okay? You have insular glioma surgery is the most complex vascular neurosurgery in my opinion. And it should be done by the intracranial microneurosurgeons, not just going there suctioning the tumor. And when you cause the trouble, you need to know how to deal with that trouble. I'm not saying cause the trouble and deal with it. Avoid always troubles, but when you cause the problem and you are a surgeon, you're gonna encounter these problems one day. And in this case, I injured the one of the M2 branches, okay? And initially I couldn't see what I injured. I put the paddy there. I further dissected to get the proximal control. What I am doing right now, I am doing the vascular neurosurgery, like aneurysm surgery. I'm going proximal and distal to the problem. Problem, I cause a small cut, you see here, while I am dissecting in the M2 branch. So I stopped the bleeding without panicking. I got the proximal control, I got the distal control, and I sutured the hole. Okay. This is vascular neurosurgery. And the rest is okay. You can remove it, you can do whatever you want to do. Okay. And this is the result after that 6-7 centimeter insular glioma. And the next region I like to talk is the thalamus. I think I still have 5-6 minutes maybe. Thalamus is a very important region, okay? So many tumors truly inoperable if they are extensively bilateral and very advanced disease or old ages. I don't suggest, but young patients, you have to, if this is glioma or metastatic tumor, you can remove tumors from thalamus. And there are millions way of reaching the thalamus. Avoid transcortical entry if you can. It's not the end of the world if you have to do transcortical entry, but use sulcus, sulci to reach at least to the bottom of the sulci to minimize the cortical damage. Okay, so this is a case, perfect case for anterior interhemispheric transcallosal approach. Okay, it's coming
It's,
here,
it's,
coming to the ventricular surface, and you can dissect the choroidal fissure to get the third ventricular part. But since it's coming to the lateral ventricular surface, you don't need to dissect the choroidal fissure, but you may need to dissect the veins, especially thalamus street vein, to preserve the vein. Okay, ipsilateral side down. Again, please, extreme caution, pay extreme attention to preserving these bridge veins. So you don't want to have a venous infarct. Is ipsilateral side down. Its frontal lobe falls away from the falx. You go to the ventricle. Immediately you see hemosiderin staining. That's the hemorrhagic part of the tumor. Okay. So then you first identify your normal anatomy, identify the pathological anatomy, coagulate the choroid plexus. I am doing some choroid fissure dissection because I want to free this thalamus street vein. I don't want to get problem from that. But tumor
excuse
is
me,
there. Yes.
excuse me, you can take more time if you want. There's no time limit.
Oh, okay, okay. So I'll go try to fast. Still, I like to respect the time, but maybe 5 minutes more. So
Okay.
this is the thing. Okay, see this I'm doing using anatomy to get there. I am using the microsurgical techniques I gained from the vascular neurosurgery because I think intracranial neurosurgery should be complete. We should not define ourselves. I am a skull-based surgeon. I am a cerebrovascular surgeon. I am a glioma surgeon. I am a microneurosurgeon. Okay. So now you're gonna see the border between pathology and the normal. In the thalamus, you don't want to try supramaximal, supramarginal resection because thalamus is very eloquent. I'm getting to the bottom of that tumor, which is the floor of the third ventricle. And I until I see the aqueduct, I won't stop. I'll keep going it. I'll keep dissecting, removing, debulking, removing, debulking, removing. And if you have an endoscope, at the end, you can put endoscope to inspect. But you cannot do this surgery with endoscope alone. Okay? If you claim you can do it, you'll do like a partial resection. So thalamus street vein is still preserved. Okay, I'm gonna go slowly, slow, and I'm seeing the aqueduct. I'm done. Okay, that's the end of the case. And since you are here, you can go ahead and do endoscopic, and not endoscopic. You are there. You can do microscopic third ventriculostomy because these patients eventually develop CSF issues. So address the CSF problem and remove the tumor and last piece of the tumor there, achieve gross total or near total resection or whatever you aim to. Okay, that's the bottom floor of the third ventricle. No brain, continuous brain retraction, and this is what we achieved. Another case, deemed inoperable by many centers. I showed this case many times. So it looks bilateral, but in reality, it's not bilateral. This is an extension. And here I thought a lot about this case, how I should approach, because the other centers recommended biopsy, stereotactic biopsy, radiation chemotherapy. She's young and she wanted to try the gross total resection with me. And I found eventually occipital interhemispheric approach is the best approach. And that's what I did. Yes, we studied this many times. We recently published a two-part paper in Journal of Neurosurgery about thalamic gliomas. If you have time, please read those. And occipital interhemispheric approach. Again, veins are rare in this location, bridging veins, but if there is any, you have to dissect and move away so you don't avulse these veins. If you avulse it, maybe nothing is going to happen, but there's a chance occipital lobe may get a venous infarct. So why are you taking risk, right? And if you retract the falx. I am retracting because I don't have a CSF yet. Once I get the CSF, brain is going to be more relaxed, and you can use other things like a lumbar drain to get this region. Tumor, once I start getting the tumors, it's okay. Then you need to pay attention to the internal cerebral vein, and that's all. You remove the tumor, you don't remove the normal brain, and you can achieve gross total resection. Okay, that's what we did here. Okay. Tumor was originating from the right thalamus as I predicted. It was not bilateral bithalamic tumor. And patient did very well, 41 months. Unfortunately, 43 months, she had multiple recurrences. She survived almost 4 years, but she did everything she could. Okay. She was not on steroids. She didn't need shunt. She did everything she wanted to do. She traveled all over the world and she died in peace. Okay. And another one, 6-year-old. This is a previously biopsied GBM at outside facility and shunted. There is a shunt. Ventricles are collapsed. Okay. I thought there's no way I can come interhemispheric or any way to reach this tumor. So that's why I did the transcortical approach in this one. And you want to be low in this, so you want to minimize the chance of damage to do visual pathways. Okay. So that's what we did. But again, how I'm going to minimize. Instead of going transcortical, I am doing transsulcal approach. I am taking my time. It's very tight fissure, tight sulcus. But you do again, take time, and then you practice this in the lab. You'll be able to do these surgeries. Okay, so I spent all my life in the lab, and I use Tenno suture retraction and so not free the not self-retaining retractors. I skip that part. That helps me. Yes, I'm using adjuncts, but at the end, I am doing the surgery. Okay, and I need to find the bottom of the sulcus, and then I'll enter transcortical and wider dissection. So I minimize the retraction damage. And yes, I'm using again the navigation. I'll get into the ventricle, I'll get into the tumor and removing the tumor. Rest is just tumor surgery. Okay. And this is what we did. Transcortical, yes, is bad, but that's best I can do them because ventricles were very collapsed. And but I gave him a good many years. And the brainstem. Brainstem is another area we worry about it. Yes, there are inoperable tumors in the brainstem, especially in the pons. They tend to be diffuse pontine gliomas. I don't recommend operating unless patient develop a focal high-grade lesion. You think you can remove that part and help to the prognosis. But in focal brainstem lesions, midbrain, pons, or medulla, you can remove it. Okay, so this is the case. We use the transcollicular approach. Look at this lesion, and there's a focal lesion in the brainstem, mesencephalon. So we come supracerebellar, infratentorial, localize the superior and inferior colliculi. Sometimes it's localizing is not easy if they expand it, but anatomy dictates fourth nerve. Once you localize the fourth nerve, you know where the inferior colliculus is. So you can enter unilaterally through the colliculus, okay, or colliculi. But if you do bilateral damage, that's bad. But unilateral, you can enter, and Yonekawa published about this case, this approach, okay? And that's what we did. Focal lesion, supracerebellar, infratentorial approach, and we removed the only lesion. You cannot do very aggressive resections here like a supramarginal because you are right there. See, everything is right there. Everything. So you need to be very careful, stay within the boundaries of the tumor, and no Parino syndrome because it's unilateral and as the vertical gaze is not in the colliculus. We know that. And now we are done with the gliomas. If I have time, I'd like to show a couple of skull-based tumors. So this is an anterior clinoidal meningioma. It's encasing all the ICA, M1, and A1. Okay. So the people said, you are 75, you already lost your vision, is only you are seeing the light. Why you worry? I worry because if this tumor start compressing the chiasm, which is compressing, and if you start losing the left side vision, this patient is a very active 75, but actively working, healthy. So why we worry, right? We worry about the vasculature. Yes, we can explore everything, remove as much as we can, and if possible, remove everything. And how are you going to do that? With the anterior clinidectomy, because it's going to give you proximal control, and it's going to give you early exposure of the optic nerve and the optic canal, and then exposure of the clinoidal ICA. Okay, this is optic nerve, optic canal and roof. This is the rest of the clinoid we are removing. Now I have clinoidal segment. I have proximal control. What am I going to do? I'm going to find the distal control, like aneurysm surgery, right? Proximal control, distal control. And now that's the optic nerve is severely compressed, and that's why she has only light perception. So what I'm trying to do, exploring. Yes, I found part of the M1. I'm okay now. I have a control over the problem. So now I need to debulk, gain space, and dissect. Debulk, gain space, and dissect. If I think tumor is invading the adventitia, I stop there. I remove the carpet of the tumor on the vessel and remove the rest of it. But if you But you need to be prepared. And this patient, you have to do angiogram, you have to do balloon test occlusion, all that stuff. Yes, you do it. You gain as much as information you can. And then I'm making small steps and I'm testing now. Is this tumor invading the adventitia? Am I going to have a trouble now? I got the bifurcation A1 now. A1 is severely involved with the tumor. So tumor is above, tumor is below. And also A1 perforators are involved here. I need to be very, very careful with that. Okay. So you see the M1, A1 perforators. And A1 is small. And I'm changing my planes, dissecting away, and bisecting the tumor same time. So I'm dividing tumor into compartments so I can expose more. Now, another important vessel are the superior hypophyseals here. Okay. Superior hypophyseal arteries is going to be here. Where are they? I don't know. I'm going to see it. Now I got the glimpse of them. I'm going to remove more pieces, explore more. Remove more pieces, explore more. One by one, small steps, but progressive steps. Okay. So now I feel better. I clean the tumor from the main parent arteries. All I need to do, clean the tumor from superior hypophyseals. Make it smaller. Don't get ambitious. Use your suction as a dissector, choroidals, perforator, A1 perforators, pushing the tumor from there and removing, making small pieces, gaining space by removing tumor pieces. And now I got everything. What am I going to do next? I'm going to remove the clinoidal dura. So then I can achieve Simpson grade 1 in this skull-based tumor. I'm going to remove all the disease-involved dura, including the clinoid, including the optic roof, optic canal dura, everything. So I'm giving them my best chance, and that's what you achieve. And I told patient, your vision may not come back, but at least we prevent the future problem. And I did my best to remove this tumor. Okay. And believe or not, in 3 months, she started counting fingers on the right side. Just counting fingers, that's good enough for her. And her left side and chiasm is perfectly fine. And this, another skull-based tumor. Patient comes with the numbness in the face, dry eyes, swallowing difficulties, double vision. They do transnasal biopsy, chondrosarcoma grade 2. They send him to do proton beam. Radiation oncologist thinks proton beam is not going to touch this large tumor. Look at this. And he refers patient to me for surgical debulk. Okay. I'm going to stop in a few minutes. And this is the tumor, okay? And I suspect this tumor may obstruct the ICA. I do angiogram. His left ICA is not filling, but there are good collaterals, which makes the surgery much easier. I don't have to worry about the petrosal ICA, cavernous ICA. And surgery is the skull-based surgery. Peeling extradural dura, peeling the dura of the temporal lobe from the cavernous sinus, clinoidectomy, exposing more, going towards the middle fossa. This is all tumor. And the trigeminal nerves, V1, V2, V3, pushed by the tumor towards you. And middle meningeal here. And we are removing the tumor there, stimulating the GSPN, finding the GSPN and the geniculate ganglion. So now we're going to go there and remove the bone over the V3, V2, so I can manipulate them much easily. And then finding a space between V2, V3. I am completely extradural now. Okay. This is the chondrosarcoma. I'm going to remove everything. And somebody's drawing something on the screen. And then removing piece by piece. And drilling that disease bone, okay? Drilling the disease bone. So I don't want to leave any tumor nests in the clivus and the petrous apex. Drilling the petrous apex more, and at the end, I'm going to go to the posterior fossa, cut it, tentorium, cut the superpetitus sinus, and this is the intradural part of the tumor extending into the posterior fossa. Okay, it's soft tumor, remove it safely and drill the bone more because there are nests, and then put the endoscope at the end. Any residual, maybe there's small one there, yes, and then remove the rest of the tumor with the endoscope and pack the area with the fat. And now it's like he's not 2 years, he's like 8 years out, no tumor recurrence. I'll stop here. This is a foramen magnum meningioma. You can do foramen magnum meningiomas. Just you need to pay attention to anatomy and surgical techniques. You can watch this video. So it's doable things. Okay. So I'm gonna conclude I'm not gonna say I did like this million times. I have always wonderful results, but the one thing I learned over years, you have to spend some time in the lab. Okay. Lab is important. Lab to learn the anatomy, neuroanatomy, skull-based anatomy, whatever you are doing, spine anatomy, peripheral nerve, learn all these anatomy, okay? Without anatomy, you have no guidance. Anatomy is your navigation. And watch, read, listen, watch your master surgeons, watch your mentors, and go to lab, dissect. Then you go to the real operating room. Then if you do that, you'll realize you understand the problem much better. And you'll perform 100% better. Okay. So that's our anatomy lab. We welcome everybody. And we provide not only training in this lab, also worldwide, online, offline, and sending the microscopes to the poor countries. And near 400 people came to this lab last 19 years. And we are very grateful to them. We learn from them. And it's an excellent environment. Okay. So thank you for your time. And thank you for giving me this opportunity to talk to you. And I wish you have a wonderful weekend, and happy to take any questions.
Yeah, Matt?
Thank
Okay, I'm sorry. Go ahead.
Yeah, thank you so much, Dr. Professor Sakaya. It was a very informative session. We had a raised hand, Dr. Mario. I believe it was you. You could go ahead.
No, I didn't raise the hand, but I'm happy to comment. I mean, the beauty of this presentation is that effectively, Mustafa, what makes you so special is that you present things in a very easy way, and they, you address from medical students to very senior surgeons. Everyone has something to gain from your talks. This was beautiful because we went through cases that, as you correctly say, many say they were inoperable. I believe that they were extremely challenging, and still you found a way to dissect in little pieces so that everyone, even from our juniors, could understand what you did, why you did. And look, that's really the way we should have, mentorship in neurosurgery, senior people that can take by hands anyone and elevate the practice all over the world. So congratulations, it was very beautiful.
Thank you, Mario. Thank you very much for your nice comments. I appreciate it. And very important points. I didn't realize what I am doing, but as you gain experience, is important to address even the simple things in a way that junior people can understand. Thank you very much. I appreciate it.
Yeah, excuse me, Naima. We have Victor Hugo Perez, world-renowned neuroanatomist. Perhaps he wants to comment. Victor?
Hello, Professor Mustafa. Really amazing dissections. As you said, laboratory dissection is the secret to make a good surgery. So, what about the chondrosarcomas recidivas? in your experience? Because recurring chondrosarcomas are frequent. So in your experience, have you made total resection of these malignant tumors? No recurrence?
The recurrence all depends on their grade. There are three grades of the chondrosarcomas: grade 1, 2, and 3. Grade 1 and 2, grade 1, if you completely remove gross totally, you don't need adjunctive treatment. They don't recommend proton beam. Grade 2 is questionable, gray area. Some people, even with after gross total resection, they will radiate. I am in that group. Even if I am 100% certain I remove gross totally, I will radiate grade 2s. Grade 3s are cancers, and definitely you have to proton beam after even gross total resection. Regarding if you leave tumor behind intentionally, I think in those cases, if I realize I remove tumor, I like to go back and clean more, because if it is grade 1, I am avoiding by gross total resection, I am avoiding the postoperative radiation. And grade 2, I'm giving the patient again the best chance to respond to radiation, or without radiation survive many years without progression. If I encounter residual tumors, if they come to me after surgical resection and radiation and there's a residual, but it's not growing, if it is grade 1 and 2, I will observe, and I won't do anything until they start growing again. Grade 3s, grade 3s are cancer. You have to be very aggressive and radical with the grade 3s.
Thanks, Professor.
You're
Really
welcome,
amazing.
Professor. Thank you very much. And I appreciate your efforts teaching anatomy and spreading the neuroanatomy, and it's well appreciated. Thank you very much.
Thanks, Professor Mustafa. Thanks.
Thank you, Professor.
Renema?
Okay. Yes, we have two questions in the chat. Dr. Ahmed, if you can hear me, would you like to take those questions?
You can go ahead.
Okay. So Dr. Mustafa, Dr. Armani is asking, what was the outcome of the thalamic glioma resection? And can the radical resection cause any morbidity and mortality?
Yeah, and actually, that's why I was referring to. We published my experience in 42 thalamic glioma patients is the last December, published in Journal of Neurosurgery. There are two parts. I suggest you read those papers, but I can tell you, out of 42, we have no mortality, and one patient had 30% of the patients got worse immediately after surgery, motor or speech difficulties. Dominant thalamus, you can get temporary speech problems, and the non-dominant thalamus, you get a motor deficits or sensory deficits. They were temporary, except one patient had a permanent upper extremity weakness out of 41, and when she was still active, and she wasn't paralyzed, but she had a weakness, a residual weakness from the surgery. So, and two patients required ventricular peritoneal shunting, despite I attempt to do all CSF third ventriculostomy in all these cases. Two patients require. None of the patients had surgical complications like bleeding or hematoma or stroke from the surgery. Since the publication of that, I think now I have probably around 50 thalamic glioma cases, and I don't have mortality and the same results. Yes, they get weaker in some cases. They get weaker immediately after surgery, but after a couple of days, they start improving. What I use to predict that, motor and somatosensorial evoked potentials. If your motor and somatosensorial evoked potentials during surgery remain unchanged, even patient wakes up hemiplegic or significantly weaker, it's going to get better after the surgery.
Naima?
Okay, thank you, Dr. Mustafa. I hope Dr. Rahman, that answers your question. We have another question from Dr. Harshad. He's asking about the Sylvian fissure and the limitation of resection of tumors.
Sylvian fissure and the limitation of the insular gliomas. That's what he meant, probably.
I believe, yeah.
Okay. So there's in insular.
Hello, Professor.
Hello.
This is Dr. Arshad Parekh from Mumbai.
Hi.
Hi. Yes, I am asking for insular gliomas, perisylvian, insular, opercular. What extent you go for a radical excision? What is your landmark where you stop not to excise further?
So low-grade gliomas, they won't pass the basal ganglia. Okay. They stop there. They respect that. And most of the high grades do the same, except very rare GBMs can go to basal ganglia and anterior perforated substance. Okay. So in the insular glioma surgery, when you start getting the basal ganglia, you see the difference in color. Basal ganglia color is going to be more brownish and with the white nutmegs. That's my limit.
Do you radiate all the gliomas post excision?
Oh, that's like a matter of discussion 2 days. So yeah, that's not only glioma is a very general term, right? There are so many different gliomas, different molecular profiles. So grade 2, 3, 4 astrocytomas, we radiate, even if after gross total resection.
Many a times in awake craniotomy, we stop at certain spots when we start finding that now the deficit is coming or there is a drop in the neuromonitoring, and we leave some tumor behind. So do you follow up that tumor or you just upfront radiation?
If it is, again, there are so many factors play role, right? So the exact grade, molecular markers, right? MGH methylation, IDH mutation. There are so many other things. If it is astrocytoma, is the IDH mutant, not non-mutant? So if you leave residual or gross total, if it is 2, 3, 4, you're gonna radiate. But I try not to leave any residual behind it. If I do,
At
I'll
times
go.
it becomes difficult. You can see the vessel going through the tumor. And many a times, as you were showing, the adventitia is involved in the tumor. You have to leave the tumor behind.
Yeah.
And at times we cannot make out this vessel is going to inside the tumor or it is just an adherent to the tumor.
Yeah.
And
then you have to leave.
the supply.
You have to leave some tumor. You have to leave some tumor. But the gliomas usually, except some gliosarcomas and some rare GBMs, glioblastomas, they don't invade the adventitia. Meningiomas do.
The same I'm asking about the meningiomas when you leave behind WHO grade 1 and mostly we leave behind because there is adherence to the major vessels. Then
Yeah.
do you upfront radiation or
No.
it is not a Simpson grade 1?
No. If you leave small tumor, resection is not total, and is grade 1, you just observe, because you eliminated the major blood supply to that residual by removing most of the tumor. upfront radiation will create more problems in the future of that patient. And you closely monitor that residual by serial MRIs. If it is grade 2, 3, that's a different story.
You have walked through the whole brain today, wonderfully shown all the results. You have shown all varieties of the tumors as usual, wonderfully. And very important for us to learn the surgical anatomy, pathological anatomy, apart from the learning because anatomy gets distorted by the pathology. So it's very
Correct.
important to learn. Yeah. Thank you very much. Excellent.
You're welcome. Thank you.
Okay, Don, I think we can have one more question before closing up. So, Professor Mustafa, we have a question asking about the proton beam radiotherapy. In settings of its absence, what are the alternatives option?
If you don't have proton beam is not widespread, even in the United States, not every center they have it. So you can do just conventional radiotherapy.
Okay, I think we have one more question. We can take one more question. So we have a young neurosurgeon. He's asking in resource limiting settings, what are the primary things that he can do to prepare himself? First, navigation, the operative monitoring or image guiding with ICG or ALA or intraoperative MRI before he goes for microsurgical complex intracranial pathologies.
How he wants to improve himself or herself?
Yeah, he's asking about his approach. Should he expertise in vascular neurosurgery first, or shall he go for microsurgical complex intracranial pathologies first?
Oh, this is again a long discussion, right? Depends on what level is this junior surgeon. So if you are resident, you are a long way to go. So you need to do many things. You need to learn anatomy, okay? And don't confine yourself in the one area. So we are living in a global era, right? You can watch many surgeries. You can watch anatomy dissections. You have access to the anatomy books, anatomy atlases. Dr. Perez, Professor Perez has beautiful dissections. So there are so many resources. Okay, so if you can watch this video, today's webinar, that means you have access to internet. So that means a lot. Okay, so you can learn many things through the internet. There are microscopes, tabletop microscopes like this. Okay. I have one in my office. Okay. We buy these small microscopes and send to the low income and middle income countries. They can practice at home. You don't need animal. You don't need cadavers sometimes. You can use gauze. You can even I seen people do noodle practices, suturing. And there are so many things you can do. And we publish these and we publish papers. So first, follow my advice. Start reading. And be aware literature, be aware the basics, principles. Then learn anatomy. Then do the dissections, whatever material you can use. And go do something else. Don't confine yourself in one field. Okay.
Name, I think Mario has a question.
No, it's I just wanted to follow up on this. There was one very important sentence that Mustafa pronounced during the talk, is that many are now subspecializing, And eventually, in our elective practice, we will end up doing mostly one or two type of surgeries, and we do it very well. However, here is the truth. The truth is that you cannot just be a glioma surgeon. You cannot just be a vascular. You need to be a very good basic neurosurgeon. You develop your expertise so that when you encounter challenging cases from your own call, you are never out of your depth. That's the key. And challenging cases will always test you, and that's what is said. You create more space, you control, you make sure you are in a safe zone, you make sure you understand your anatomy, so that you have always control. You have always control on what you're doing. You anticipate the possible complication. That's the only way you can get better and better results. When I started 20 years ago, we had no opportunity to see people operating on those complex cases. We had no opportunity other than some books. And oftentimes, by the time you have the book, it means that it was written 2 or 3 years previously. The speed of access to high quality training nowadays is ubiquitous. Everyone in the world who has access to internet can get in touch. You have Professor Vitor Perez, we have Mustafa, you have Arshad, you have all great names, people with a lot of years of experience, and they are ready to share with all those trainees. So I think this really fulfills the scope of global neurosurgery that we're all trying to contribute to.
Thank you very much. Thank you, Mario. A very important point, Mario emphasized again. So just don't limit yourself with your. Don't say, hey, I have limited resources. I had limited resources when I was first time resident in Turkey. We didn't have a CAT scan in 80s. Okay. We used to do direct carotid injection angiograms to diagnose the subdurals. So, but I learned a lot from that. Future of microneurosurgery, I'm telling you, is not in the United States, is not in the Japan, is not in Europe. Is low income and middle income countries with the limited resources, because you have to push yourself to do better surgery. Anatomy is there. Anatomy is the same anatomy. Galen, Vesalius, Yaşargil, Retzius, they describe same anatomy. Anatomy hasn't changed. Microsurgical skills, same skills. If you train yourself, you don't need to be super skilled. We are not born with the skills. Okay, you train yourself. You run 100 meters. Usain Bolt, he didn't run 100 meters right away. He didn't go to the podium and I'm going to run 100 meters. I'm going to break the world record. It took how many years for him to train? How many years to train to run marathon? So we need to be a neurosurgeons running marathon and running 100 meters same time. That's what Mario was telling. That create a space, sudden move. That's 100 meters speed. And then marathon, you remove by time. You take your time. That's the sacred time between you and your patient. Okay, respect that. Don't rush the things. So that was, I think, that's very important points Mario emphasized. So one more last thing, I have to go. Unfortunately, one of the panelists asked. Yaşargil told grade 2s normally, grade 2 astrocytomas or gliomas don't need radiation, post-op radiation. That's a different era. Please read the new literature about gliomas, how these molecular markers and genetics, tumors genetics, not the patient's genetics, affect these. Grade 2 astrocytomas are not benign tumors. Okay, so just forget that. They are low-grade tumors and high potential to transform to the high grades, especially with certain molecular phenotypes. So I have to stop here, unfortunately, and I appreciate all the comments and the participants uh, participating this event in the weekend, Saturday morning, making time. Thank you very much. Have a wonderful weekend.
Thank you
Thank you.
so much,
Thanks, Professor
Mustafa,
Mustafa,
for being
for
there.
this
Thank you.
Thank you.
amazing lecture. Thank you so much.
Thank you very much. Thank you,
Thank you,
Professor.
Thank you.
Professor Mustafa. We'll see you again.
Thank you. Thank you.
Heard
Thank you
you,
very
heard
much.
you many times again and again.
Yeah, we'll
Love to hear.
try to do. Yeah, I'll talk with
I love to
Ahmet.
hear you more.
Thank you very much. Thank you.
Thank you,
Thank
Professor,
you.
for the amazing webinar. We also appreciate it for having your Excellency with us today. And of course, I wish we can have much more webinars together. This webinar just make me much more exciting and motivated to have more lectures with your Excellency. So thank you, so Professor, and I'm so appreciative for you.
Thank you, Ahmet. Thank you. Thank you. We appreciate your
Thank you,
efforts.
everybody. We'll see you
Well
next
done.
time.
Thank you, John. See you.